more of a conversation. So with that, I bring you a shift in perception, innovative modalities for palliation. And I always like to start with this story, because this is really why I ended up here in this space of this kind of medicine, and it's because of patients like John. And John was a 48-year-old crisis care patient of mine, which meant I went and saw him in his house for a couple 12-hour shifts to try and really manage his pain. And this gentleman had a lot of existential terror. He was young, and he did not know what was next. He was not in alignment with his soul, his spirit. He was really struggling with that piece of the puzzle when we talk about end of life. And he was using cannabis. He's one of the first patients I've had using cannabis in hospice, and there was a lot of stigma around that. But I watched as cannabis really enhanced and potentiated the pharmaceuticals that he had really reached ceiling max doses at for a lot of these meds. They just weren't touching him, and they were causing really terrible side effects. And this gentleman was just the spiritual piece. He was so afraid to die. And when he did use cannabis, that was the time in our 12 hours that I was able to start to kind of touch on that and maybe create some palliation and help him work through some of those touching points of what comes next. What do you believe? What are your thoughts? Where's your comfort? Are you afraid? What are your regrets? And really chatted. And that's really all I could offer. I called in the social worker, we called in the chaplain, as nurses do. We coordinate care, we provide support. But this gentleman, it wasn't enough. It wasn't enough at all. So I want all deaths to be good deaths. And I know Marcy feels the same about that as well. So, with these patients, we have this need to share this information about these modalities because we've seen it work. And we've also seen how a lot of hospices and end-of-life care push away or stigmatize this type of healing and medicine. And we're really trying to bring a voice to this space and hoping that we can bring you some information through John's story, so that you can really go back to wherever it is that you are working and have more confidence that you need to be sharing this information with patients. It's our duty as nurses to share the information and have no judgment, but to support, whatever healing journey or whatever path, particularly in hospice and an end of life. And so I sat and I held space for John for a lot of time, and we had some really good conversations. And when it came down to it, I was the nurse that was there when he died, and that man died staring directly into my eyes. We had used all of the pharmaceuticals we could and had on hand. And the only comfort I could bring in that moment was to not break his gaze, to stay with him till the end, to reassure him that he was surrounded by love, and to not be afraid. And I get goosebumps every time I say that last piece, because that is all I could provide. That was it. And I had to just hold space for that. So, and I know if you've been a nurse, I am sure you have a similar story of a patient that has just profoundly touched your life, where you wish you could have done more. You wish you could have provided additional comfort or information, or you wish you had certain information. So I feel very called to take stories like John's and really share them with nurses, because we are a powerful the most powerful population in healthcare. So this information is absolutely, necessary to be shared. And again, poor John had, suffered with existential terror. And I know that we can do better with that piece and that mental part of letting go and end of life. And that's why we're here to spread more of that information today. A little bit about me. I'm Jamie Rollins. I've been a nurse since 2004, which just seems crazy. I'm also a yoga instructor. I've been a business owner since 2018. And I really love helping thought leaders create health-centric spaces to share plant medicine, holistic medicine, psychedelic medicine. I offer business consulting services for healthcare folks, and I do direct patient care through my company, True Health Consulting. Let's see. I had a whole long list of other things, but I hate to talk about myself so much, but the reason I actually have any sort of credibility to talk about this information is because of the amount of time I've spent in hospice and home health and community health. I also have a really strong background in psychiatric nursing, in the whole lifespan, from children to geriatrics. So I've spent a lot of time working in the mental health space and realizing how very vital this piece is to our holistic care and practicing as nurses. That that what we're hearing now, which Heather talks about, that conscious nursing, that how are we really taking care of patients? And a lot of us are pulling away from what we've been really told, and really now looking at more information and really more how it feels. So I love to help people create spaces like this. I'm not an academic. We need more folks in the academic space to be doing things like research on psychedelics and cannabis, so we can destigmatize it. We can take away the power that I guess there's a hold, that power that says this is not appropriate or this is not the right path for people. That's our job as nurses. We're the ones that do that. And we really do need to put a spotlight on these life-changing and healing modalities. And we're seeing that more and more, as you're going to see presented in, Colorado, in Oregon. I really wish Heather was here today to talk about the amazing changes that are happening in Oregon with psilocybin and end of life. So this is truly a turning point. Let me give you a little background quick about just in general, like overall timeline of some psychedelics and cannabis. So you can see how it all kind of fits over the last 100 years. So 1918, cannabis is on pharmacy shelves. We're using it for pain, sleep, nausea, other ailments. 1932, Albert Hofmann synthesized LSD. And this happened in Switzerland. And what's funny is that LSD was synthesized from a fungus known as ergot. And this was essentially folk medicine and had healing properties, this ergot. And he synthesized LSD from a fungus. So we talk about psilocybin, being fungi. It's just interesting to me how the psychedelics, circles around the fungus. 1950, the role of neurotransmitters was discovered in the as like how they work in the brain, how important they are, and this is really what is thought that most psychedelic medicines have an effect on, is these neurotransmitters, either blocking or attaching receptors in the brain. 1955, we had Gordon Wasson experience a psilocybin trip. And he came back and told the Western world in Time magazine about these magic mushrooms. And then in 1962, we have ketamine that graced the scene. And that was synthesized by Kelvin Stevens, a chemist and a professor of organic chemistry. And then, let's see, we've got 1950s to 60s. This is a time period where psychiatric medicine was using LSD, was using psilocybin. In fact, the founder of AA, Bill Wilson, he credited LSD for his spiritual experience that led him to stop drinking and led him to create a program that's recognized all over the world to help people maintain their sobriety. So that's just one of those, I love that, one of those facts that's just so interesting, very full circle-y kind of thing. And then we have 1970s, the war on drugs, drug scheduling, the substances that were demonized and just stigmatized, and groups of people were segregated because of all of the drug wars. So this is a huge piece if you're interested in cannabis medicine or psychedelic medicine, and I'm still diving in to understand all of the pieces. But 1970, that was a really pivotal point for all of this information, research, healthcare in that time frame. So if you're a history buff, definitely dig into that. 1977 to 85, MDMA, says ecstasy. I mean, this is used by a few dozen psychotherapists in the United States because of its benign, feeling enhancing, and non-hallucinogenic properties. They were using it for couples therapy and marriage counseling, and they were having really wonderful effects. It was taking the emotion intensity out of the situation, so people could look at it and have really just, general conversation without the intense emotion surrounding it, which is what they're looking at for PTSD, to basically get through the phase 3 clinical trials. So we'll probably see ecstasy, MDMA, legal for use in prescription fairly soon. So keep an eye out for that. In the early 1990s, the FDA approved the first human trial exploring whether MDMA could help relieve pain in terminally ill patients, which is interesting as well. Um, and how it serves as an adjunct to clinical psychotherapy. And like I said, the clinical trials are really for post-traumatic stress, but they're also seeing how it's helping anxiety in autistic adults and patients with terminal illnesses such as cancer. So here we are now in, the 2000s. We've got this psychedelic renaissance essentially on our hands. And we're looking at where ketamine is legal to prescribe and use in all 50 states. So that really is our point of access for psychedelic medicine now, across the board. And it's not like cannabis in the sense that it's schedule, one, we can't, be talking about it. Well, we can be talking about it, but we can't really be prescribing, right, from Schedule 1. But ketamine is legal. So like everybody who comes up against me was saying like, well, what about ketamine? Like, it's legal. It's our main point where we can go to right now, even easier than cannabis, to get people some relief when it comes to existential terror at end of life. And medical cannabis is available now. The latest stat I had since I've done this a couple months ago was 41 states, DC, Puerto Rico. Psilocybin's now been decriminalized in 2 states. And we have research being done to back up these claims for improvement in diagnoses such as depression, pain, suicidality, anxiety, addiction, and grief. Although, we definitely need more research. And we need more people interested in seeing how these substances and these modalities can really benefit that psychosocial spiritual component, and that really important part of end of life that oftentimes gets ignored in our main healthcare stream, because hospice, end of life, palliative care is a very different focus and way and perspective to look at nursing. It's not fix. It's holding space. It's how do we make this quality time. So it's a very different almost mindset. And we really are coming full circle now. I mean, there's a lot of movement with healthcare professionals supporting alternative therapies because we've seen how the others have not really worked. All right, let's see. So, I mean, like I said, what's happening right now is that we're shining a light onto psychedelics, and people are they're tired of being sick. They're tired of feeling this way. They're tired of looking for solutions that aren't working. They're tired of going to a medical system that isn't providing them answers. And so they're not waiting for doctors anymore to give them an answer. Like, what's the issue? How do I cure myself? They're going to go cure themselves, and they're looking for information all on their own. So this is really a powerful time for nurses to step up because people are having their own autonomy for their mental health and physical wellness journey. Essentially, it's a journey for many. It's not all cut and dry in the same, this is how we heal cancer. This is how we do this. It's not a prescribed regimen for everybody's the same. We know that as nurses. And we need to really we need to spread that, because that's not actually how it's being done in healthcare. Everybody's like a cookie cutter system, and we're not cookie cutters. We have individualized care, and that's where a lot of these modalities come in. It's really providing and helping individualized care for our patients. So currently what's happening is we're having this sad epidemic, right? It's this epidemic that we're talking about: suicide, addiction, anxiety, depression. I mean, the stats are just just astounding. And I know we're talking mostly about end of life, but these are just really important things to just include. I mean, suicide is a leading cause of death in the United States. 3.2 million people have planned a suicide attempt. 1.2 million have attempted suicide. And there, 132 deaths a day due to suicide in 2021 was one of the stats. So this is an issue. This is a mental health issue. And even people who are, dealing with hospice and they're in palliative care and end of life, they have contemplated these things as well. This is not out of the norm. Anxiety it's insane. 264 million adults around the globe have anxiety. And I always care to venture that is not an accurate number. I always and this is totally my perspective, but I always think this is underreported because I just don't think people actually know what their experience is anxiety most of the time. They're just living with this weight of just the heaviness of the world and don't realize that that is actually anxiety. So 6 million experience panic disorder out of that 264. And often it coexists with depression. So the other thing is that anxiety costs approximately $42 billion a year in healthcare expenses. I mean, addiction is running rampant in this country, costs $700 billion a year annually. Approximately 50% of individuals with a diagnosed mental illness will also struggle with a substance abuse, that self-medication component. They're really finding how wonderful a psychedelic experience, led, guided, a process, a therapeutic treatment can be really helpful in the addiction space. There's a ton of interest, obviously, and research going into this area in particular with ketamine, with psilocybin, with cannabis. And I know a lot of spaces that have been touched, a lot of people who've been touched and be able to remove alcohol from their daily use using cannabis medicine therapeutics. So we again are coming through, we are coming full circle. Depression, I mean, this is something that really plagues our end of life and palliative care patients for obvious reasons. Some stats for depression: 2015 to 2020, depression rose the fastest among teens and young adults from 12 older. Sorry, doesn't have a palliative care connection, but again, interesting stats. This is something that we're really dealing with. And if it's affecting the young, guess what? Soon it's going to be affecting the old. So in the end, it's going to relate. So depression among adults in the United States has tripled in the early 2020 months of the global pandemic, and jumped from 8.5% before the pandemic to a staggering 27% during. They have some new research through Boston University School of Public Health, and that's showing an elevated rate of depression has even persisted through 2021 and worsened, actually climbing to 32.8%. So essentially, depression affects 1 in every 3 million Americans. 3 million Americans, 1 in every 3 American adults. So, I mean, that's kind of a staggering statistic. Like, that many people are depressed. So yeah, these are modalities that can hopefully do something about it. And, this is full circle part 2. Like, why are we here? Like, why are we even talking about psychedelics and cannabis and alternative modalities so strongly right now? It's because we've had such ineffective treatment for the last however many years. SSRIs were supposed to be these amazing meds that really turned everything around. And not to say that they have not been effective, helpful, or life-saving to patients. Please don't think that's what I'm saying. But they have not been as effective as medical professionals had intended or had hoped. There are still a ton of undesirable side effects with these pharmaceuticals. And, quality of life is not as improved as patients had truly hoped. So, and we're seeing over time more and more meds are being added. So it's not just like you take an antidepressant and you're feeling better. Oftentimes it's like, you've seen the ads, add Abilify to your current antidepressant, ask your doctor today. And with cannabis and psychedelic medicine, it's kind of doing the reverse of that. It's a harm reduction model and method, essentially integrating cannabis and pharmaceuticals, moving away from that pharmaceutical load. Oftentimes, the more cannabis we use, the less pharmaceuticals we need, because the cannabis potentiates those pharmaceuticals, so we can use less, so we can decrease that pharmaceutical load on our livers. Harm reduction. So a lot of these meds are doing that. A lot of times, cannabis and psychedelics don't need to be used at the amount or at the rate. We'll talk a little bit more as we go through, but psychedelics are not a good business model. Neither is cannabis, because oftentimes you figure it out and you don't need to have as much. So that's not what pharmaceutical industry does. So we're really duality, polar opposites of how we're looking at treatment, how we've been trained as nurses, and how the healthcare system and insurances and pharmaceuticals. And then really what we are seeing and witnessing and know here as healers is not in alignment. And so here we are. Here we are finding alternative solutions. We are going out and we are reaching for them ourselves. We are not waiting. We are making sure that we're doing nutrition, lifestyle, talk therapy. Oops, going a little ahead of myself. Talk therapy, herbalism, meditation. These are all things that are now being integrated into our typical health, right? So we're kind of like, it's amazing that we're seeing this now. Cannabis, massage, Reiki, alternative energy healing, because providers are getting desperate. I'm sorry, I'm a little bit of a little clear my throat, little throat chakra thing here going on. So psychedelic medicines, you've already kind of heard me mention ketamine, psilocybin. I consider cannabis psychedelic sometimes, depending on its use in setting. LSD, MDA. We're going to go a little bit further right now with ketamine, psilocybin, the cannabis. You're not going to hear me talk about ibogaine, ayahuasca, peyote, San Pedro DMT in this presentation, but stay tuned and join our group of CNN members if you haven't already, because we do things like discussions and presentations like this ongoing. So really great place to connect, to continue to learn more about all of these topics. Side note. All right, so what's the appeal of psychedelic medicine? Why do we want to include these modalities at end of life? And it's because people are getting relief, and they're getting it quickly, and they're seeing lasting results, oftentimes with 1 or 2 treatments, depending on the psychedelic. So once people learn that this may be an option for them after being so hopeless and thinking that they may have relief from some of the anguish, you see that hope begin to rise in them. That's one of my favorite things in doing anything, any kind of medicine, any kind of healing, any kind of working with patients, is when you see that light or that flicker or something, there's something comes back to their eyes and they realize, wow, okay, there's something else I can try. Maybe that will. And that's all we really have when we're in that space, is that hope, hope that the suffering will stop or get better or end, and then because there's hope, oftentimes that leads to curiosity, which leads people to connect more. So that curiosity leads to connection, and psychedelic medicines offer an opportunity for so much connection that we're so deprived of in today's society. Connection with others, connection with community, with oneself, with one's higher power, all humanity. People are disconnected, and at end of life, to give somebody the ability to connect with all that is their God source, their higher power, their families is a tremendous blessing. I mean, it's really one of the greatest gifts you can give, those final connections with family, and those final connections with self and spirit. And then once you're, connected, you have this surrender. You can let go, and realize, what will be, will be. You can let your ego go, come to an understanding of the reality of the situation, objectively removing the emotions and allowing what will be to be. And again, once we surrender to the process, we can really, truly, like that feeling of letting go and of whatever we were holding, that fear, to be able to let go of that fear and let those walls down, creates basically a release. You can break free from whatever chains or beliefs were holding you back, any patterns that had you stuck, and have this kind of growth at end of life before their transition is a tremendous gift to both the patient and their families. You let go of all those emotions, those thoughts, those stories that don't serve people, especially at the end of life. And when you can connect to the greater whole and surrender to the flow of life and release what no longer serves you, you're left with peace. And with peace comes increased consciousness and awareness. And with increased awareness comes healing. So this beautiful chain of events is like this water flow of just this natural process. And it's truly beautiful to witness. So why psychedelics are beneficial at end of life, and for palliative care, a lot of times pharmaceuticals and soft skills will fail. And then what's next to ease these unmanageable symptoms of pain, anxiety, depression, or, the most distressing symptom, which I think is that existential terror, which again, that's where I believe my patient, John, he was such a powerful motivator for me to look into that more and to understand that piece more, because it's a highly burdensome form of suffering, especially at end of life, and we do now have, as as you're going to learn more about, we do now have treatment options. Ketamine is available right now to help people move through some of that intense fear and anxiety and depression at end of life, so they really can embrace those moments and hopefully have the good quality end of life experience with family or friends or whatever it is that they need to do before they leave. And a lot of research is being done currently. John Hopkins is a leader in the field. NYU, both leaders in this space right now with psilocybin end of life research. Um, you know, I mean, the biggest reason to be incorporating this modality in hospice and palliative care spaces is because it's been shown to ease suffering, to decrease anxiety, to improve a sense of peace, dissolve the ego, and decrease overall fear of death. Why aren't we already using these modalities? It's infuriating to me at times when I learned about cannabis and the fact that like nobody was talking to the end of life patients and my hospice patients in Florida about cannabis medicine and that it could possibly be helpful to them because they all qualified for a medical card. And I was appalled that nobody was telling them that this is something they could use. And it was all hush, hush. Really began my advocacy then because I believe it was so powerful to be able to be utilized, and patients should at least have the knowledge to make their own decision. That's vitally important. Because if you're a nurse, you know that the reason we do this is to bring peace and healing. And I just don't see, we suffer enough in this life, just doing life, to be able to end it and have a good end of life is just, I think that we all should have that. All right, so a little bit of a deeper dive. Let me see, I've lost my spot. Yeah. I guess I haven't. Thanks for your patience. I'm definitely pushing my tech skills, working my 3 screens here. I got going. So again, I'm just going to chat briefly. Psychedelics, ketamine, psilocybin, and cannabis is really what we're seeing being used right now in the space. And the others, they're really not yet into the move here. But we have ketamine. So ketamine there's a lot of misinformation about ketamine out there. I talk to people about ketamine and the first thing they say to me is, oh, it's a horse tranquilizer, or yeah, let's go into a K-hole. Both things are true. Yes, it can be used recreationally and it's abused, and people identify as a big K-hole, or oh yeah, it's a tranquilizer for big horses. And the most important thing about ketamine is that it's just the safety profile it's an incredibly safe. It has an incredibly safe safety profile, meaning that it is really not a depressant. It's not a depressant on respiratory. It is one of the safest medications we have. It's on the WHO's list of essential medicines. It is used every single day in pediatric anesthetics, putting kids to sleep for surgeries. So and it's been around for a long time, 40, 50, 60 years, right? So, this is not a new medication. What's new about ketamine is that they're discovering its mental health benefits at all these years later. So that's the exciting piece, because we do have research on how it's affected people and, side effects for these last years. How safe is this medication? So it's been really interesting to see it being used in the space of treatment-resistant depression, imminent suicidal ideation, people who are truly suicidal and they have been hospitalized within 24 hours. They're seeing turnabouts of that headspace, no longer suicidal. So it's a really amazing medication. Not to say that it won't have risks and that it should not be studied more. But it's been really powerful to watch ketamine really help people get a different mindset, lay some different neural pathways down, different ways to think about things, and really create some peace and anxiety reduction. That's what I've seen personally from folks who are using ketamine. And again, it doesn't need to be like every day. It's like oftentimes a one-time experience. Maybe it's 2. Sometimes with treatment resistant, there's a treatment series of 6 every 2 sessions, every 2 sessions a week for 3 weeks. So 6 sessions total. But oftentimes end-of-life patients need 1 or 2 experiences, and they can get a value out of the ketamine. Let's see. So although it was initially developed as an anesthetic, like I said, we're seeing it have come across diverse settings and helping in pain management, depression, addiction, anxiety, and a lot more. So it's very exciting to see the research and where it will go with ketamine. Let's see, how am I doing on time, Mars? Am I doing okay? All right, cool. All right. So, some of the challenges that we're seeing with the use of ketamine is truly just breaking stigma. This really needs an educational campaign similar to cannabis. And I think cannabis nurses are the best nurses to be going into psychedelic medicine. I wrote a little blog on that on CNN website as well because of this, because this is such a hard part. This is a mindset piece. Nurses in general are good at being non-judgmental, holding space, and truly, hopefully, as our job, dictates, we're not judging people for maybe the choices they've made. So breaking stigma and dealing with challenging subjects and dealing with challenging comments and, approaching those situations with love and not anger, but the intention to educate. There's a lot of education that needs to be done with psychedelics and with cannabis. So that's really one of the challenges is people don't really understand how beneficial this is and how safe it is. They're afraid still, and I'm really trying to remove a lot of the fear surrounding this medicine in particular because it's so beneficial and because it's legal right now, right here, and we can use it today for our patients. Again, I would love to see more research, especially at the end of life stage. It's new. We need to be adding this to getting some grants and continuing to do research in this department so that we can go up against these hospices and say, look, it's going to cost you less money on pharmaceuticals if you implement maybe one session of ketamine, and it will give our patients a better, peaceful, calmer end of life, which is our goal. So we just need to keep chatting. And insurance coverage. Actually, something was just released recently where it was a challenging venture to try and get some insurance to cover ketamine. And you could do a super bill of sorts. However, they are going to be instituting a CPT code January 2024 for psychedelic medicine. So that's highly encouraging because that means that the insurance companies, if they're getting a code, it means the insurance companies are taking it or going to be thinking about taking it. So that is really hopeful to see that move this quick. And if that happens, then I think we're going to have more of a chance to get this modality into the hospice space. So I'll be keeping an eye on that for sure to see what happens as we round out this year and come into next year. Psychedelic medicine. Let's see. So I'm just going to touch a little bit on some of the end of life studies. So with pain, so current clinical research, pain is showing that intractable or refractory pain has been reported to occur 10% to 20% of patients with cancer. It's difficult to control with just opiates alone. And the development of chronic pain and intractable cancer pain appears to be related to the activation of NMDA receptors. So ketamine is suspected to have mechanisms of action which block those NMDA receptors. So that might be helpful in the link to how ketamine is helpful in decreasing pain. Evidence was varied regarding its efficacy, which is why we do need more research in this area. Because they don't fully understand how ketamine works in the brain for these pieces. And that's what's exciting. Glutamate, GABA, all of those neurotransmitters and how it's being affected. But the NMDA receptors seem to be a very large piece of how ketamine is effective for these areas. So, we need pain management possibilities that don't include opioids. And, we understand the terrible effects as palliative care and hospice nurses, and just as nurses in general, with constipation and tolerance. And, it's just opioids are hard. So, there's a great variance in practice regarding the dose, the route, the frequency, and delivery of ketamine. Which is also a reason why we need more research specifically focused on pain and depression and these areas so that we can get more specific in dosing and how it would be helpful. Microdosing ketamine is being explored also for pain, and it's done over a series of weeks' time. But best practice is still being formulated here. So it truly is still a trailblazing space for pain management, but there's so much potential. It's truly enormous. And it's used as a co-analgesic for poorly controlled pain, especially neuropathic pain, to reduce the use of to reduce the amount of opiates used, to help relieve anxiety, depression, epileptic seizures, and as a bronchodilator. So, I mean, isn't that kind of funny? It's like what cannabis, right? Cannabis potentiates medications to help reduce pain, things like that. So that's kind of interesting how they co-regulate each other. Depression, anxiety, end of life studies. There was one open label study. They had 14 subjects. And subjects had symptoms of depression and depression mixed with anxiety. And they received daily oral doses of ketamine. And they did that for 28 days. And then the primary outcome measure, the hospital anxiety depression scale, that was used to rate the overall depression anxiety symptoms. And they rated these symptoms 3, 7, 14, 21, and 28. And then the results were over a 28-day trial. They saw significant improvement in both depressive symptoms and anxiety for the 8 subjects that did complete the trial. 100% of the subjects completing the trial responded to ketamine for both anxiety and depression. A significant response in depression symptoms occurred by day 14 for depression, and day 3. So they're finding it took a little bit longer for real full relief for depression, and then like within 3 days, anxiety was relieved. So end of life anxiety, existential terror. Again, even though there's not a ton of folks in these research studies, they're doing more. These are encouraging results, and I'm sure you can already see why they would be beneficial to our hospice and palliative care populations. So another study they did was a retrospective pilot study, and that showed a rapid positive response on the anxiety of patients in palliative care. Patients in palliative care setting administered IV ketamine, not oral this time, and they showed a significant reduction in anxiety with the scores that they were noted before and after. Findings showed that psychological distress with patients in palliative care may improve after a single administration of ketamine, which mainly alleviates anxiety in those patients. So, this is really exciting work. There's a psychotherapist up in Washington. Her name is Allison Drazen, and she's been working at the Ames Institute in Seattle, Washington, with hospice patients and supporting them doing treatments and finding ways to get the hospice to financially cover those ketamine treatments. So it is being done. Right now in the United States, it's just not being done by a lot of people. Ketamine is inexpensive. Considerably compared to other pharmaceuticals we use in the end of life space. So it would be great for hospice organizations' budgetary needs. There really isn't a reason a hospice organization shouldn't cover this type of treatment measure. So here's just a little quick guide on right now what they're saying for administration and dosing for ketamine. IV, IM, troches, bioavailability obviously best with IV. And yeah, we can just moving through my notes here, and then here I'm gonna scoot along. I feel like I should be further ahead, but that's all right. It's a lot of information. I really love sharing it, so I'm glad you're here to receive it. Thanks for being here. So what's happening today, right? We have continued research. We have clinics opening, ketamine clinics, home service ketamine clinics are available. You can have your doctor order troches and be able to do something like a lozenge at home. So you have multiple options for delivery. Hospice covered ketamine treatments are happening, and we really need to be having that happen in more hospices. So what can you do right now to bring this conversation to the space that you're in? Bring psychedelic advocacy to your organization. Bring the research, talk about the research, because, they don't want the woo woo. They want the here. This is the information here. Johns Hopkins did this. New York University. These are universities that have stature and respect and are leaders in their field. So bring research. That's what speaks to physicians, directors of nursing, chief medical officers, chief nursing officers, is the research. And begin educating yourself and continue to educate others. Always continue to share information that has been helpful to patient stories. Share these anecdotal stories that may not be considered as evidence, but you're a nurse, you're the front lines, it's the eyes and ears of what's happening out there. And to be able to share information and even stories of other nurses, it's really powerful. So this is Heather Shelton. Again, she's not here. She did this piece. She wrote up the piece that we're going to talk about on psilocybin. And I'm just going to quickly cruise through some of this as we talk about psilocybin, because this is really the next up and coming psychedelic that we're going to, be able to have access to already in Colorado and Oregon. So let's see. Just gotta roll with the punches. All right, we're going to do a little brief timeline here as well. Psilocybin in 1955. Well, we'll start with a bit of history through 50s and 60s. Psilocybin was studied for alcoholism and other maladies. 1955, psilocybin was brought to the attention of the Western world after an article in Time magazine. In the beginning, I shared this with you with Gordon Wasson's experience with mushrooms. Then he published this article, and it really did spark interest, and research began in earnest. And then 1962, there was an experiment called the Good Friday experiment at Harvard. And it was hypothesized that psychedelic drugs, in this case psilocybin, could facilitate a mystical experience in religiously inclined volunteers who took the drug in a religious setting. Both the 6-month and the long-term follow-up questionnaire results showed greater than 60% of the subjects who received psilocybin experience positive persistent effects in the attitude and behaviors. And then the experimental subjects described the Good Friday psilocybin experience as having had essentially the elements of a genuinely mystical nature, and characterized it as one of the high points of their spiritual life. So really huge benefits for the Good Friday experiment. In 2000, John Hopkins was approved to reinstate the psychedelic research and be a leader in the field. And they have been for the last 20 years. So Maria Sabina, we want to take a minute to honor her because of the fact that her life was basically destroyed because of her sharing this medicine. So Maria Sabina, she was a Mazatec curandera and a shaman for a long line of healers using psilocybin mushrooms for healing. And these mushrooms were used in ceremonies to cure the sick. And like we said, Gordon Wasson found Maria and had this experience. And he brought some mushrooms home to France, and then the mushrooms became part of popular, essentially, counterculture in both Europe and the United States. And people from all over the world started to go to see Maria in her small hometown, and basically overran the city. She became criticized, ostracized for sharing this with the Western world, and the act of honoring nature and plant medicine in itself created a sacred healing to occur, but this practice basically ruined her life. So we just wanted to take a moment to bring that to space. So I just want to touch on some of the research that's happening. Palliative effects of psilocybin treatment in cancer patients. This was one of the largest and most rigorous studies on psilocybin. It showed that a single administration of psilocybin produced large and sustained decreases in depression and anxiety in patients with a life-threatening cancer diagnosis. This landmark study provided the basis for the initiation of the registration trials in the United States and Europe, seeking approval of psilocybin for medical treatment. So that was a huge win. And then the potential for psychedelics for end-of-life and palliative care. This was a 2022 Johns Hopkins study and found the majority of participants who had experienced high-dose psilocybin in clinical research reported that this experience being one of the most meaningful experiences of their entire life, essentially right up there with a birth of a child or a death of a parent. And then in 2020, an article was published in the Journal of Psychopharmacology, suggesting that psilocybin-assisted psychotherapy facilitated improvements in psychiatric and existential distress, quality of life, and spiritual well-being. And then at the 4.5-year follow-up, approximately 60 to 80% of participants met criteria for clinically significant antidepressant or anti-anxiolytic responses. So, I mean, we're talking about really, really huge results for these kinds of medicines. So what's happening today? So legalization, like we said, in Oregon and Colorado. Oregon program, you have trained facilitators and approved facilities. And like I said, Heather Shelton, who is a member of CNN, she's opening a integration facility called Epic, and it's in Eugene, Oregon. It will be the first in the state of Oregon, hopefully within the next few days, actually beginning to treat patients with psilocybin mushrooms. So it is happening, and one of our members is the first to participate in it. So super exciting. Colorado is decriminalized for adult use, and they're waiting on licensed facilities. So, when we talk about what you need to know as a clinician, it's really the legality. So, and same thing with the cannabis space. We really need to just understand, what with each setting, with each state, what are the rules? What are the barriers? What can we do and what can't we do? And there are barriers to research, public funding, all of those things. So, 2 seconds. Things for your patients. I want to make sure that wasn't okay. So yes, that's the first thing. If you're going to start thinking about psychedelic medicine in any sort, or even cannabis medicine, just know what the rules and regs are in your state, and be cognizant of that. Set and setting. So if you're new to the space of cannabis or psychedelic medicine, set and setting is critical. It's really critical. It really helps. It really can be the determining factor, honestly, in a lot of these experiences, with a altered sense of reality consciousness. So it's super important the patient feels safe, that even just like comfort, safety, privacy, is the space aesthetically pleasing. The effects of psychedelics create a vulnerability in participants. So safety and trust of that facilitator relationship is truly of the utmost importance. And for the general physical location, safety is really important. That's why an at-home setting is really lovely if people are really comfortable at home. Or you see some of these clinics that are have very beautiful settings, comfortable chairs, soft blankets, things that are all like sensory, good music, smells, lovely, fresh plants, things like that, to really create the environment of ease and peace, and set that vibration. Other thing is, as a clinician, like in anybody's talking to you about psychedelic medicine, there's preparation that you should do. There are intentions that should be set. There's research that should be done. This isn't something you just say, all right, let's do it. Let's do it tomorrow. No, there should be some conscious intention going into why these are being chosen as modalities to help with healing or transition. And the same thing goes with integration. After a client has any kind of experience with a mind-altering substance, you want to ask them how they feel. We would do the same after somebody maybe started taking pain medication. It was their first time with pain medication or anxiety medication. How did you feel? How did it affect you? Did you have there is an integration piece with psychedelics and cannabis. We have an added benefit of being able to speak about any sort of trauma that might have come up, any sort of beautiful imaging, any sort of intention setting that maybe feels in alignment. It's any release of fear. There's a whole different component that we get to really talk about when we work with psychedelic or cannabis medicine, opposed to straight pharmaceuticals, but we do the same. The integration just looks a little different in this space. So, Marcy, I don't know if you want to pop on here too, because, jump in at any point to talk about, palliative care provider role, because a lot of people, I think, have, different opinions about this. As what is our role in psychedelic medicine as a palliative care provider? You do not need to be directly involved in the experience, but you do need to be able to offer support for a patient in just general, because we're nurses and because we don't hold judgment. We're responsible for directing patients to resources if they ask. If we don't know information, what we would do in any other situation, we'd maybe research it ourselves and then share the information that we've received to help the client on their journey. And then, speak up and vote. We need voices to be protecting end of life care. And to speak, yeah, to support our work. This is not exactly an easy subject to support. So, um, it's needed. Psilocybin, ketamine, and cannabis are three really powerful modalities that we need more information to get to the ears. We need more stigma to be broken. So now cannabis is the last part of the presentation here. Go back one. Beautiful image. I just love. She's such a beautiful plant. Um, Miraculous healer. Uh, Quick touch on the legality. Medical programs in 41 states, District of Columbia, Puerto Rico. 23 states allow recreational use. In 2018, the Farm Bill legalized the use of hemp products nationally, all but two, actually. So those two states are Idaho and Nebraska. Cannabis remains a Schedule 1 drug, unfortunately, federally. So that means that it is defined as drugs with no currently accepted medical use and a high potential for abuse. So we have enough research at this point that tells us cannabis does not fit this description. Schedule 1 drugs are heroin, like LSD, ecstasy, compared to Schedule 2 drugs, cocaine, methamphetamine, methadone, Dilaudid, Oxycontin, fentanyl. Those are Schedule 2, so those are considered to be less harmful than LSD, MDMA, and cannabis. So it's just interesting who makes these rules and how they've stayed put, and the reason we can't get them changed. So cannabis has, again, an incredibly safe profile. There's no lethal dose that's ever been identified, which we can say about very few pharmaceuticals. The federal status, has inhibited research in the U.S. for the last 50 years. And much of our early research came out of Israel with Raphael Mechoulam. And then research here in the U.S. and abroad have shown that cannabis needs to be rescheduled or descheduled. So, pain is the main reason that us as nurses, cannabis nurses, get consulted, because they have pain and they're not getting results. So, pain is distracting from life and it increases the rates of depression. And if we can alleviate the pain at end of life to give patients better days, we want to do that. Treating pain allows increase in interactions, family, friends, and just, increase quality of life, which is our main goal. And then here's a little bit of research. The 2017 study, we're looking at 984 chronic pain patients, including those with neuropathic pain, back pain, arthritis, post-surgical pain, so a variety of pains, headaches, abdominal pain. 2/3 of those patients reported pain relief as the main benefit of the cannabis use. Improved sleep was the second most commonly reported benefit. A study reported in the Journal of Pain showed a 64% reduction in opioid use amongst chronic pain patients who use medical marijuana. These patients experienced fewer side effects and improved quality of life. Evidence that cannabinoids are effective for chemotherapy-induced nausea and vomiting is among the strongest available in the medical literature. Let's see. This is the 2017, the National Academies of Sciences, Engineering, and Medicine performed a review of the health effects of cannabis and cannabinoids and found that 48% of oncologists believe that cannabis is equal or superior to standard antiemetic therapies. This same survey reports 64% of oncologists have seen cannabis be effective for increasing appetite. A study of 2,000 medical cannabis cancer patients in Israel showed that 91% of patients ranked nausea and vomiting as the symptom most improved by cannabis. Donald Abrams, a well-known oncologist in Southern California, and he stated that in addition to benefits in managing pain and nausea, cannabis is the only antiemetic agent that also can increase appetite. And this is something, cachexia is something that affects our end-of-life patients often. There are limited options for appetite stimulation in the pharmaceutical arena. Many patients report, getting the munchies after cannabis use. Cannabis can raise the levels of ghrelin and leptin, which are the two hunger regulating hormones. AIDS patients using dronabinol, which is the synthetic THC, had an average of 10-pound weight gain over 1 year. And in one study of 18 cancer patients with anorexia, 13 of them reported an increase of appetite with 2.5 milligrams of THC taken 3 times a day. So this is a quote from Dr. Bonnie Goldstein. She's a leading expert in the medical cannabis field who works primarily with pediatric patients. And she reports that both THC and CBD relieve pain, improve sleep, reduce anxiety and depression, and stimulate appetite. All the symptoms we manage with pharmaceuticals at this time with mixed results. So the harder to quantify and increasingly important aspects of cannabis medicine, are the spiritual and psychological and emotional gifts that this plant brings. Utilizing cannabis, CBD, THC can bring a sense of peace. Again, that sense of peace, which elevation of mood, the ability to, really feel lighter in essence, is give us this shift in perception so that you can be brought into the present moment more, which is truly where we experience life and where we want our palliative care patients to be, is in the present moment with loved ones. We don't, serves us no benefit to be thinking about what the future holds or what the past has had, because we only have the present. So a lot of these modalities bring us into the present moment, which is so beneficial and healing in itself. And so I'll end this presentation with so Ira with these 4 lines. A Dartmouth physician, Ira Byruck, author, has written about these 4 sentences that are really truly like pivotal points at end of life to be, really kind of thinking about and having that shift in perception. Please forgive me. I forgive you. Thank you. I love you. And psychedelics and cannabis medicine can pull us into these spaces a little bit easier, can give us that extra hand to get into the space of forgiveness, to get into the space of gratitude, to sit in that space of love, to sit in that space of vulnerability, to ask. So, and there we have it. So I will stop sharing this screen so that we can chat further about thinking outside the box and utilizing psychedelic medicine in this space of end of life.